Okay guys, this is our second lecture about muscles, and we're going to start by thinking about active insufficiency. So back when I was in PT school, there were images like this. This, by the way, is not me, but we've learned something about muscles and a lot of other things since the middle of the day. One of the things that we've learned about is the source of the loss of muscle tension with active or passive insufficiency. So it was believed that the reason that we could not get any muscle tension when the muscle was shortened across all joints, in the case of muscles that cross several joints like the long finger flexors or extensors, was that indeed the sarcomeres were so overlapped that there were no cross bridges available. What we've learned since then is that actually isn't the case. As we saw in the last lecture, in living organisms, including humans, although the number of cross bridges will affect how much tension a muscle is able to generate, it will never get so long or so short that it actually has no cross bridges. I have a little video of something that I want to show you, and something that I think you should do on your own while watching this lecture to help understand active and passive insufficiency. By the way, you should have heard my younger son complain when I asked him to give up 60 whole seconds of his life to help me make this video.
The reason that you can't extend your fingers if you're holding your wrist extended is because of active insufficiency of the long finger extensors and passive insufficiency of the long finger flexors. The reason that you can't extend your fingers if you're holding your wrist.
Although it is true that all muscles have the same length tension curve, which is what we're talking about, it isn't always observable in all muscles. So the diagram on this slide over on the left is showing the length tension curve of the biceps and other elbow flexors as we go through the range of motion. And that is unsurprising. There are a few factors here at play, but consider the biceps and elbow flexor length tension curve. We see the peak of the curve here, where we also have about mid-range of the joint angle. However, with the hip abductors, we don't see such a peak. We see rather that they have their greatest torque at about 10 degrees of adduction over here, and we never actually do see a peak. We see that the torque that we're able to generate with the hip abductors just goes down kind of linearly to its end range of abduction over here. And this is what I want you to think about actually as a discussion question. How could this be? Is it because those muscles are fundamentally different than all the rest of the muscles, or is there some other factor? Another factor that influences the amount of tension that a muscle is able to generate is its direction of contraction or direction of activation and its velocity. Now this is a factor that you're going to have to concentrate on really carefully because it really blows the mind of a lot of people. But over here on the right end of the curve is very rapid concentric muscle activation. That is to say that your muscle is shortening and shortening very rapidly. As your velocity slows down, you're able to generate more and more tension, as we see. So over here we're getting slower and slower in the concentric muscle activation range until finally we get to the isometric activation range. So we see that isometric is actually in between eccentric and concentric. So here we're slowing down, slowing down, slowing down until finally there's no movement at all. That is isometric. Now, what we start with is slow eccentric. And so we see that slow eccentric is able to generate more tension than either the isometric or the slow concentric. And the faster that we get into the eccentric, the more tension we're able to generate until finally the amount of tension levels off. So in the rapid eccentric muscle contraction, we hit a peak of the ability to generate tension, and that tension plateaus. This three-dimensional graph is demonstrating both of those factors which we have just described at the same time. So on the x-axis, or the right to left axis, we have sarcomere length. And this bar right in the middle that I'm drawing over right now is representing the optimum sarcomere length for generating tension, which, as we described before, is 2.2 microns. The z-axis, or the front to back axis, represents velocity. So over on the front end of the front to back axis is the very rapid concentric exercise. The bar right in the middle, that's shaded, that I'm going to draw over right now, represents the isometric or zero velocity contraction. And as we get into the higher tension, it is muscle tension that's generated on the vertical axis. As we get into higher tension, we get into the rapid eccentric till finally the amount of tension plateaus. It plateaus very high, but it plateaus within the rapid eccentric velocity range. Muscles have different roles relative to each other. So if we are to consider elbow flexion, for instance, the biceps is one of the main agonists of elbow flexion, and the triceps is the main antagonist, or the muscle that goes in the opposite direction. One thing that you may not have thought about as much is a muscle that is called a synergist, but I'll give you an example. In order to make a strong fist, and go ahead and try it now as we're thinking about it. Make a strong fist, and you're going to see that your wrist extends somewhat. And the reason it does that is in order to make to maintain a decent length tension relationship of the long finger flexors. So we need, in order to shorten across the fingers, the same muscles have to lengthen across the wrists. So the wrist extensors, the two radial wrist extensors, and then the extensor carpi ulnaris, are synergist to the long finger flexors because they allow the long finger flexors to work better. So earlier we talked about how length and velocity can affect the tension that a muscle is able to generate, but also the input from the nervous system has a big effect through recruitment and rate. So we have talked about, certainly in biomechanics before, and I think we have talked about this in anatomy as well, that muscle spindles are nerve endings within muscles, and the way the myotatic reflex, that is the tendon tap reflex, most commonly that you know in the knee, but there's a lot of other places where it will work as well, causes the jerk in muscles that when we tap a tendon, we apply a very quick stretch to the muscles, and the muscles in response, through the stretch of what is called the intrafusal fiber, or the nerve ending that our muscles have to tell us about muscle length, when they are stretched in that way, they will cause a very vigorous reaction in the extrafusal, or the much bigger muscle fibers that actually generate muscle tension and cause the tendon tap. Another thing that's important, we talked a little bit about Hilton's law, first identified in I think 1850s, but the skin is the biggest proprioceptive organ. So for example, the quadriceps is innervated by the femoral nerve. if we put our hand in the cutaneous distribution of the femoral nerve, we will also stimulate the quadriceps by giving more input to the femoral nerve through the skin. I'm now going to show you some electron micrographs of animal muscle tissue to show you what happens with immobilization. So here what we see are healthy sarcomeres, which are mostly, as you see, actual contractile proteins. But after just 5 days of immobilization, what you can see is that the sarcomeres from the Z discs are becoming way less organized, and you begin to see what is fatty infiltration. And then after 14 weeks of immobilization, we see almost completely fat with very little evidence of contractile proteins. We still see the Z disc, but we see mostly fatty infiltration. So the takeaway from these few slides is that with immobilization, what happens is that we lose contractile proteins, and those proteins actually even within the muscle fiber are replaced with fatty tissue. When a muscle is immobilized in the shortened position, the loss of contractile proteins and atrophy is unsurprising, but what is interesting is the change in sarcomere length. The reason that sarcomere length increases is when a muscle is immobilized in a shortened position. Remember that the sarcomeres want to be at 2.2 microns. So the muscles will reabsorb sarcomeres from the ends until the length of the sarcomeres in their new shortened position is 2.2 microns. Once you take away the immobilization, which might be a cast in the case of the fellow in the drawing, then the muscle returns to its more normal length, but the sarcomeres are more stretched out. That's how you have a decrease in sarcomere number and an increase in sarcomere length. The sarcomeres are in a relative state of passive insufficiency, and the whole length tension curve of the muscle has moved to the left, as you see in the second diagram. If muscles are immobilized in the lengthened position, the effect is similar, but in the opposite direction. The muscle will add sarcomeres until a resting sarcomere length of 2.2 microns is achieved in that lengthened position. Once the lengthened position is more normalized, then the sarcomeres are much shorter in a position of relative active insufficiency. And what you have done is move the whole length tension curve of the muscle to the right. All of you have experienced delayed onset muscle soreness and probably minor muscle injury. What happens with minor muscle injury is microinjury. Injuries to sarcoplasmic reticulum, contractile microfibrils, titin. Remember, titin is the elastic fibrous protein which holds the Z discs to the myosin myofibrils and the capillaries. So that's an important thing to think about, but the consequences of that type of muscle injury are very small. We'll think about some of the more severe types of muscle injury over the next few minutes as well. So if somebody has a first-degree muscle injury, that is exactly what we were just talking about. However, a second-degree muscle injury is when the muscles may be torn through their fascicles, and people who have this type of injury will experience significant swelling because muscles are a very vascular tissue and significant loss of tension. A third-degree muscle tear is complete or near complete rupture through the entire width of a muscle belly. However, surprisingly for me, complete recovery is possible if connective tissue envelope survives the muscle tear. And we'll describe how that is over the course of the next couple minutes. So if a muscle fiber is torn through, or many muscle fibers are torn through, Although the connective tissue envelope is preserved, this is how healing takes place. First is inflammation, and the inflammation causes necrosis of the muscle fibers that have been damaged. The necrosis causes chemical triggers to be released that facilitate the healing process, such as first the formation of the microvascular bed, which is called granulation tissue, that supports fibrosis, or the formation of scar tissue, which are mainly disorganized collagen fibers. The scar tissue holds the muscle tissue together, and the next phase that can happen is myogenesis. Myogenesis is when stem satellite cells can transform into myoblasts. Myoblasts burrow their way through that connective tissue, the scar tissue, and once they have burrowed their way through and are continuous with the other side of the muscle, then they can mature into complete muscle fibers. As we age, there tends to be changes in the muscle. The number of muscle fibers can decrease up to 50% after the age of 60. And this effect is especially marked in the type 2 strength-generating glycolytic muscle fibers. The number of motor units go down, but the size of the remaining motor units increase. So the fine motor control can decrease for that reason. As we have described before, because of disuse, you can have an increase in connective tissue actually within the muscle fiber itself. So the upshot of all this information is that resistance training as we age is really helpful.